Well, good morning, everyone. We are here to start the IPSOLAC webinar for all the world. Um, I'm Dr. Luis Poggi, President of IPSOLAC, and I want to open this webinar saying that the topic that we are going to talk today, it's a very important topic because we have all the questions to put in this topic because about Barrett esophagus, we have know the most important things to know and the most important thing to treat and the most important thing to resolve this complex problem. Today we have four important people from Latin America, and we have Barrett's esophagus in bariatric surgery, regression or progression. This is a very important question. It is Guillermo Ponce who is going to begin to talk about this topic, and is Dr. Sebastián Arana who is in charge to moderate this webinar. So, Sebastián, I would like to pass the phone for begin this important topic from Latin American chapter to IPSO in around the world. Thank you very much for the invitation. We are going to be here to listen all the most important thing that we are going to learn today. So, good
Thank you,
morning
Doctor.
and go on.
Thank you, Dr. Poggi. Good morning in Latin America and the rest of the world. We are happy to begin our academic activities for IPSO and IPSOLAC. As Dr. Luis already said, this topic is a very interesting and very controversial topic to talk about. So we have a great topic. We have great guests in this webinar. So to begin with, Guillermo will be our speaker. Guillermo is from Mexico, Guillermo Ponce de León, and he's a bariatric and general and an endocrine surgeon. He has training in general surgery and also in endocrine surgery by the Instituto Nacional de Nutrición and Ciencias Salvador Subirán. He also is a bariatric surgery for Centro Médico ABC, and he's also a candidate for a master in medical science from the Universidad de Anáhuac. Thank you, Guillermo, for this great presentation you're going to give us. As panelists, we have three great surgeons from Argentina and from Peru. So we have Luciano Poggi. Luciano is a bariatric and advanced intestinal surgeon and endoscopist. He works at Clínica Anglo-Americana. He's chief of general surgery from the hospital, and he's also a clinical professor of surgery at the Universidad Peruana Cayetano Heredia. He's also a member of IPSO Communication Committee. And we have also Mariano Palermo. Mariano is a bariatric and general surgeon from Argentina. He is coordinator of the education committee at IPSOLAC, and he's also a past president of the ICYLS. And at last but not least, Dr. Luis Poggi. Everybody knows Dr. Poggi. He's a general surgeon for the Clínica Anglo-Americana. He's also president of IPSOLAC, and he's also director of the Centro de Investigación de Fisiología y Cirugía del Aparato Digestivo. He's also clinical professor of the Universidad Nacional Mayor de San Marcos, and is founder and ex-president of the Honorario de la Sociedad Peruana de Cirugía Endoscópica. So we have a great guest, we have a great topic, so let's begin with our presentation. So Guillermo, you have the mic.
Hello, good morning in America, good afternoon in the rest of the world. Thank you very much, Dr. Arana, for this kind invitation. And today we're going to talk about Barrett's esophagus in bariatric surgery, regression or progression. First, I want to talk about some of the epidemiology and some of the definitions of Barrett's esophagus that I think it's really important to talk about it, because this can be changed obviously in some of the populations, and the definitions will change according to the different guidelines, American guidelines, the UK guidelines, the European guidelines, and also the definition that the if supposition statement regarding Barrett's esophagus mentions. The general population have an overall prevalence of Barrett's esophagus between 0.4 to 2%. The most accepted overall prevalence of Barrett's esophagus is around 1%. But some of the risk factors associated with Barrett's esophagus are GERD, obviously, the odds ratio to have Barrett's esophagus compared to not having GERD. And having GERD, the odds ratio is 4 to 5 times greater for those patients who have GERD, and has been described that during all the follow-up or during the time, 7 to 10% of patients with chronic GERD will have Barrett's esophagus. The second risk factor is obesity, that concerns a lot to us, okay? So, and especially central obesity, probably this is because increases the abdominal pressure and will generate much more GERD, and will have much GERD, these patients. The odds ratio is 1.4, and another risk factors that we can find are smoking, familial history of Barrett's esophagus, on history of adenocarcinoma, and an age above 50 years, and the white race. Regarding those patients who are undergo metabolic and bariatric surgery, 30 to 60% of the patients will have symptoms of GERD. And if we take these patients into an endoscopy, we will find that around 2 to 3% will have Barrett's esophagus. This has been described between 1% to 15%. And a recent meta-analysis described that the real incidence is around 3 to 4%. We're going to continue with some of the definitions. And this is very important because in Europe, most of the authors will use the UK guidelines that were published in 2014. And in the rest of the world, the authors will take account much frequently the American guidelines. And the definition, it differs from each of these. So in terms of the UK guidelines, the definitions of Barrett's esophagus is the distal squamous epithelium will be replaced by metaplastic columnar epithelium, either by gastric cells or intestinal cells. And these need to be found at least 1 centimeter above the GE junction and need to be confirmed histopathologically. The authors of the UK guidelines, they define these, or they take into account the gastric cells metaplasia, or defining these gastric cells columnar epithelium, because 50% of the patients that have metaplasia without intestinal metaplasia will have intestinal metaplasia at 5 years. So, and 90% of those who don't have intestinal metaplasia will present it or will show it at 10 years. So this is the reason why the UK guidelines supports using the presence of any columnar epithelium at the moment of the biopsy. Whereas the American guidelines mentions the follows: intestinal metaplasia is required, as this is the only columnar epithelium that clearly predisposes to malignancy. We all know that intestinal metaplasia is the real risk factor to progress to adenocarcinoma. And the IFSO position statement that was released in 2020, they only consider Barrett esophagus as intestinal columnar metaplasia. In all three studies or three guidelines, they suggest that using the Prague classification that take into account the C, that it's the circumferential length of the Barrett esophagus, and the M, that means the maximum length of the Barrett esophagus. Obviously, they suggest that need to be confirmed by histopathologically specimens, biopsies, and they suggest using the Seattle protocol biopsy that suggests taking at least one biopsy every 2 centimeters in all 4 quadrants and targeted biopsies on visible lesions, starting from distal to proximal. Regarding the follow-up, and first we need to mention that the risk to progress of Barrett esophagus with intestinal metaplasia to high-grade dysplasia or adenocarcinoma is very slow. However, we need to remember that, Barrett esophagus, it is the main risk factor to having adenocarcinoma, but the truth is that very slow the progression to high-grade dysplasia or adenocarcinoma. Only 0.26% to 0.30% of the patients will show a progression to high-grade dysplasia or adenocarcinoma per year. So, taking account of this, the different guidelines refers or propose different follow-up protocols. For those patients that have short segment Barrett esophagus, defined as less than 3 centimeters, without intestinal metaplasia or dysplasia, the UK guidelines suggest that the patient needs to undergo into another endoscopy and taking another biopsy or biopsies, and if this is negative, the patient can be discharged. For those patients that have a short segment Barrett esophagus with intestinal metaplasia or dysplasia, an endoscopic surveillance every 3 to 5 years is recommended. Regarding those patients that have long segment Barrett esophagus, again defined as more than 3 centimeters, or have dysplasia, the endoscopic surveillance can be suggested to repeat it every 2 to 3 years. Regarding the American guidelines, they mentioned or they suggest that these patients need to undergo to an endoscopic eradication therapy. After this, the American guidelines suggest that the patient needs to continue under surveillance and PPIs need to be taken forever or for long term. Whereas the UK guidelines suggest that those patients who continue with symptoms of GERD, even taking PPIs, the anti-reflux surgery can be recommended. The American guidelines do not mention nothing regarding anti-reflux surgery. So this is one of the main differences between the two guidelines. So knowing this, it is feasible to have proper follow-up following metabolic and bariatric surgery, knowing that probably in almost all the units that those metabolic and bariatric surgery, after the 3rd year, more than 60% of 50% of the patients won't have a proper follow-up. So probably we will be losing a lot of these patients. So we need to mention or we need to discuss which procedure is better for these patients and if we are doing the proper things. Some of the risk factors of progression are smoking, have a hazard ratio of 2, male gender with a hazard ratio of 1.7, the length. This doesn't have conclusive data up to date. Persistence or the presence of chronic GERD, and obviously a high rate of dysplasia will have greater risk to progress to adenocarcinoma. For those patients who don't have high-grade dysplasia, the risk to progress to an adenocarcinoma or to find or develop an adenocarcinoma, it is around 0.5%, whereas for those patients who have high-grade dysplasia, have at least 10% and has been described and even as up as 13% per year to having or develop adenocarcinoma. So we need to rule out that the patients who undergoes metabolic and bariatric surgery doesn't have this risk factor of progression, and if we identify some of these, probably we can suggest an RYGP instead of a sleeve gastrectomy, as we're going to discuss later. But also for those patients who have high-grade dysplasia, probably the most proper thing that it's going to take an endoscopic eradication therapy before the metabolic and bariatric surgery. So some of the current recommendations of the UK and the American guidelines are as following. Remember that we are talking at this moment only for Barrett esophagus, not specifically for those patients that are planning on undergoing into metabolic and bariatric surgery. This is for general population. The UK guidelines mentions that anti-reflux surgery it is not superior to pharmacological acid suppression for the progression of neoplastic progression of Barrett esophagus. That anti-reflux surgery should be considered in patients with poor or partial symptomatic response to PPIs. The American guidelines mentions that in Barrett esophagus with low-grade dysplasia, high-grade dysplasia, the endoscopic eradication therapy is suggested compared to surveillance. Regarding anti-reflux surgery, as I was telling you before, it is only recommended after complete eradications of intestinal metaplasia. The American guidelines mentions that there is not enough evidence that supports a different therapy or treatment that can improve Barrett esophagus compared to endoscopic eradication therapy. But is this really true? Well, I found this systematic review and meta-analysis where the authors try to compare fundoplication and medical therapy for Barrett esophagus. They included 9 studies. 6 studies were included in the meta-analysis, including at least 1,300 patients, from where 65% were in the medical therapy group and 35% of the patients into the surgical group. Male to female ratio was 2:1, and regarding the medical therapy, PPIs were most frequently used than the H2 blockers, 90%, and a combination of both was found in 5% of the patients. Regarding the surgical group, Nissen fundoplication was the most frequently made with 56% and unspecified fundoplication in up to 40% of the patients. The follow-up ranged between 1.5 to 7 years. Of these, 20% of the surgical group mentioned or were described having low-grade dysplasia, whereas only 18% of the patients with the medical therapy. Probably this is a bias that is will be fine because those patients will have much more symptoms, so probably the anti-reflux surgery will be offered much more frequently in those patients who have low-grade dysplasia rather than PPIs. The authors found that regression was much more frequently found in the surgical group rather in the medical therapy group. Also, progression was much more frequently found in the medical therapy group. Regarding those patients who did not have dysplasia at the moment of the surgery or the start of the different studies, they found that the surgical group and medical therapy regression was very similar. However, they found that in those patients with low-grade dysplasia, the surgical group showed an 83% of regression, at least decrease in the size, histologically regression, or complete regression of Barrett esophagus, whereas this was found only in 55% of the patients that remains in the medical therapy group. The overall regression was 43% for the surgical group, whereas this was only 24% in the medical therapy, giving an odds ratio of 4 that in favor of the surgical group to show regression after the therapy or the treatment. Regarding progression, this was much more frequently found in the medical therapy. For those patients who did not have dysplasia, the Barrett esophagus showed any progression in the surgical group in 6%, whereas this was found in 12% of the medical therapy. For those patients who have low-grade dysplasia, this was found in 4% of the surgical group, whereas this was found in almost 14% of the medical therapy, giving a decrease in almost 2/3 of the risk of showing progression after the surgical treatment. However, many of the anti-reflux surgeries, such as Nissen, TOR, TUPET, fundoplications, have poor outcomes in patients with morbid obesity. That's the reason why we're here and we're going to discuss if this really exists a progression or regression following metabolic and bariatric surgery. So we're going to analyze the current evidence regarding Barrett esophagus and metabolic and bariatric surgery. We're going to start talking about sleeve hysterectomy and Barrett esophagus, and I found this systematic review and meta-analysis that was recently published by Dr. Ponce, who is the main author of the American guidelines regarding Barrett esophagus. This systematic review and meta-analysis had a very important or relevant strength that all the studies, including patients who underwent an endoscopy selectively, were excluded. So they include studies that all patients who underwent sleeve hysterectomy have a preoperative endoscopy and have at least one follow-up. They found 10 studies with a sample size of 680 patients. And as I was telling you, all patients underwent endoscopy before and after sleeve hysterectomy. 7 of these studies have a follow-up of at least 3 years, and this is really important. But because of the findings of the authors, they found that 54 patients developed or had de novo Barrett esophagus during the follow-up, given a pool prevalence of 11% following sleeve hysterectomy. The authors did not found any significant correlation with GERD or the presence of esophagitis, but they found that the time was the most relevant factor to present or to develop a de novo Barrett esophagus. They found that 86%, an increase of 86% in the risk of esophagitis at long term during the follow-up, that gave us a risk of 13% per year of showing or having esophagitis following an sleeve hysterectomy. They describe some of the mechanisms related to GERD, and this, at the end of the talk, I will ask Dr. Poggi and Dr. Palermo, who are international experts in this topic. They describe the following mechanisms. One is the loss of the angle of Guy's flap valve and decreased pressure at the lower sphincter, esophageal sphincter, and the damage of the sling fibers at the guard. all the de novo Barrett esophagus was found in those studies that have at least 3 years of follow-up. So they conclude and they suggest that an endoscopy screening might be more useful after 3 years, and all patients who undergo sleep hysterectomy should have at least an endoscopy every 3 years. I included the following study because I think it's really interesting, because they have an state database. They give the follow-up, obviously preoperatively, and continues during the follow-up, and includes more than 80% of the patients of Colorado, US. So all those patients, or almost those patients who undergo an sleeve gastrectomy will be in this database. They included at least 5,000 patients who underwent a sleeve gastrectomy, and they continue given the follow-up, and they included the terms of those patients who underwent an endoscopy or had the code for esophagitis, Barrett esophagus, or adenocarcinoma. They found that the novel GERD was present in 18% of the patients who underwent a sleeve gastrectomy at 2 years. But at 5 years, almost 1/3 of the patients will have GERD. Esophagitis, on the other hand, was frequently found in 80% of the patients who had an endoscopy at 5 years. So probably this is telling us that esophagitis and GERD is much more frequently that we think that we will find in the sleeve gastrectomy. Regarding Barrett esophagus, they found that 0.17% for every 100 patients before surgery increased to 0.24% per 100% after the surgery. They've excluded or included a small analysis of 453 patients without Barrett esophagus before the surgery. During the follow-up, the presence of Barrett esophagus in these patients was 1.6 at 2 years. But at the end of 5 years or more, they found that 6% of the patients had Barrett esophagus. So this again shows a significant increase of Barrett esophagus following a sleeve gastrectomy. Consistent with the previous systematic review and meta-analysis, we can see here that the incidence and prevalence of Barrett esophagus in patients who have a sleeve gastrectomy will be much more higher during the follow-up. See, following the 5th year, it seems that increase. We can see here in this Kaplan-Meier that starting at 0% obviously at the moment of the surgery, we can see here that at 1 year was 1.6, 2 years, almost double, and at the end of the 5th year was 6.4%. So again, I think that all patients who undergo sleeve gastrectomy need an endoscopic surveillance. Finishing sleeve gastrectomy and Barrett esophagus, I decided to include this cross-sectional single-center study that was made in Asia, just because one thing. The white race is a well-known risk factor to having Barrett esophagus and for progression. So it is the same thing for Asian population and for the west side of the world. Well, the authors included 114 patients that did not have preoperative Barrett esophagus and had at least 1 year of follow-up. The mean follow-up was around 5 years, and they found that de novo esophagitis was present in up to 22% of the patients, as well as GERD, from which more than 95% of the patients were de novo GERD following the sleeve gastrectomy. And they found or suspected Barrett esophagus during the endoscopy in 3.5% of the patients. However, only in one patient, less than 1%, this was confirmed by the biopsy. So probably we are talking about different populations. The really Asian population have lower risk to have Barrett esophagus and for progression compared to Western countries. And now we're going to talk about RYGB and Barrett esophagus. This is the first study that I would really want to include and show you. And I really want to include this because in this study, the authors changed their protocol. At the beginning, they were doing just selectively the endoscopies. And after some point, they change and they start doing an universal endoscopy. What they found is that when only those patients who had symptoms of GERD, they found that only near to 2% of the patients who underwent RYGB had preoperative Barrett esophagus. But when they start doing universally, they found that 4.7% of the patients had Barrett esophagus. So again, I think that the prevalence of Barrett esophagus is much more higher in patients that are undergoing metabolic bariatric surgery than without. They included 19 patients with a diagnosis of Barrett esophagus. All of these underwent RYGB, and they found that 43% of the patients had histologic regression, and only 57% persisted with endoscopic findings of Barrett esophagus, this at 1 year. Recently, Dr. Muya from Germany published this article. This is one of the largest series that have been described regarding patients with Barrett esophagus who underwent metabolic and bariatric surgery. They included 74 patients, from where 40% of the patients were men. 27% of the patients underwent sleeve gastrectomy, whereas the rest underwent RYGB. They show that 40% of the patients show changes of Barrett esophagus after 3 to 5 years. And we're going to see that the findings regarding or among the procedures were completely different. This figure shows the complete sample size, and as we can see here, up to 7% of the patients had long segment Barrett esophagus. Something relevant in this study is that patients who had irregular C line were included, were taken count as Barrett esophagus if they had some histologic characteristics during the biopsies. None of the guidelines recommends including patients who have abnormalities in the C line because we don't know what to do in these patients really. So this is something to take into account, but I don't think that really take a big difference in this topic because we're going to see that the results between or among procedures were completely different, as I was telling you. The first group of patients were those patients who underwent RYGB. And as we can see here, the only patient that had dysplastic Barrett esophagus underwent RYGB, and this patient showed regression after 1 to 2 years and persisted with regression, histologic regression of the dysplastic Barrett esophagus at 3 to 5 years. Another thing that is important here is that almost 17% of patients who underwent RYGB at the last follow-up between 3 to 5 years did not have any sign of Barrett esophagus during this time of follow-up. So we can see here that it is not just that they are going to show partial regression, but up to 17% showed complete regression. And this figure shows that 60% of patients remain steady regarding Barrett esophagus. 4%, just one patient showed progression. However, almost 35% of the patients show regression. This is really important, and this is consistent with some previous studies that have reported something like this. Another thing that we can see here in this graphic is that there was a significant regression in terms of the length of Barrett esophagus. At the beginning, preparatively, many patients have a segment greater than 2 centimeters, but as we can see here, almost all the patients who underwent RYGB were in the length of near to 1 centimeter or even less. So again, RYGB showed magnificent results in this study. On the other hand, the sleeve gastrectomy showed totally different results. Unfortunately, only 5% of the patients showed regression, whereas 30% of the patients showed progression and 65% of the patients were steady regarding Barrett esophagus. None of the patients who underwent sleeve gastrectomy at the beginning had a long segment Barrett esophagus. However, during the follow-up at 1 to 2 years, almost 23% of the patients showed a long segment Barrett esophagus, and this was or persisted at the last follow-up for those patients who had an endoscopy 3 to 5 years after the sleeve gastrectomy. Also, one patient showed changes and progressed histologically, developing a dysplastic Barrett esophagus. Again, this is consistent with what we were talking about in the previous slides. This graphic showed us the differences between sleeve gastrectomy and RYGB. At 1 to 2 years, almost all the patients who underwent RYGB were steady or showed regression of Barrett esophagus, whereas for patients who underwent sleeve gastrectomy showed progression. At the last follow-up, 3 to 5 years, this was almost the same, and just one patient with a sleeve gastrectomy showed regression. This meta-analysis was published in 2020. They included 8 studies. 2 of these were prospective, and they included a total sample of 117 patients with Barrett's esophagus who underwent RYGB. And they found that the overall regression of Barrett esophagus of patients who underwent RYGB was 56%, ranging between 36 to 80% of the patients. In terms of GERD, the overall resolution was 93%, and this was ranging between 71 to 100%. There was no differences between if the patients have higher mode of regression regarding a short segment or long segment Barrett esophagus. Was completely the same or near the same. Just showing the results of the meta-analysis that 56% of the patient showed regression after the Barrett esophagus. When they made a meta-analysis comparing if patients who underwent RYGB with previous Barrett esophagus had more risk of progression instead of regression, they found that the odds ratio to show regression following RYGB was 31. This means that near to or more than 300% of the patients will have regression rather than progression. And I just want to finish with the IFSO position statement that was released in 2020. The objectives of this study were to determine the incidence of Barrett esophagus in patients undergoing metabolic and bariatric surgery, to determine the frequency at which Barrett esophagus may develop following metabolic and bariatric surgery, especially interest in sleeve gastrectomy, and determine if regression of Barrett esophagus may occur following metabolic and bariatric surgery. There were some concerns that exist before this study, and this was the reason the IFSO created a task force to analyze this. And some of the concerns were to if the modified anatomy of the gastrointestinal tract may result in chronic GERD that may increase the risk of Barrett esophagus or even adenocarcinoma. If obesity is that it's a well-known risk factor, then if patients have an increased risk before surgery, on the other hand, if metabolic and bariatric surgery, decreasing the obesity and central obesity and the intra-abdominal pressure can modify the natural history due to the weight loss, and if we are doing the proper follow-up. They include the end 56 studies. 14 of these included data regarding preoperative and postoperative of the patients. In this, they made the analysis of progression and regression. Regarding sleeve gastrectomy, they included 80 studies for the analysis with a total sample size of more than 14,000 patients. The overall Barrett esophagus rate was 2%, but when they included only studies that included data at the beginning and after the sleeve gastrectomy, the prevalence of Barrett esophagus increased up to 6%. And when the follow-up was larger than 2 years, the overall rate was 4% or even more of the patients who had Barrett esophagus. On the other hand, when they tried to analyze regression, they found that all the studies that reported data regarding regression included only patients who underwent RYGB. So at the end, they included 10 studies with a total sample of 118 patients. And obviously, all of these had preoperative diagnosis of Barrett esophagus. The median follow-up was more than 2 years, and they found that almost 2/3 of the patients had regression following RYGB. No study reporting of the incidence of Barrett esophagus regression following a sleeve gastrectomy was identified, as I was telling you. So the conclusions and the recommendations of the present IFSO position statement were the following. 1. GERD and complications should be carefully assessed before metabolic and bariatric surgery. When suspicion of Barrett esophagus exists, biopsies should be taken according to the Seattle protocol. Dysplastic Barrett esophagus should be treated before metabolic and bariatric surgery. In long segment Barrett esophagus or dysplastic Barrett esophagus, a sleeve gastrectomy or one anastomosis gastric bypass should not be performed. This is probably a concern because no single study regarding one anastomosis gastric bypass has been reported in terms of the comparison of regression and progression of Barrett esophagus. The following recommendation is that in short segment Barrett esophagus, sleeve gastrectomy or RYGB could be discussed with the patient, and obviously RYGB is the preferred procedure. Following sleeve gastrectomy, it is recommended an endoscopy at 1 year and then every 2 to 3 years. Finally, the IFSO encourages further high-quality studies to be conducted regarding Barrett esophagus and metabolic and bariatric surgery. There are some mechanisms that have been proposed to explain why Barrett esophagus can show regression following RYGB. The first one is that exists a decrease in the amount of acid and virtually all bile reflux into the distal esophagus. The second one is that will exist a continuous drainage of the acid produced in the cardia through the gastroduodenal anastomosis. The third one is obviously a decrease in the abdominal pressure, this because of the weight loss and the consequent decrease in central obesity. The next one is that exists a fixation of the gastric pouch in the abdominal cavity by the root sleeve, and this can decrease the risk of GERD and migration of the gastric pouch through hiatal hernia. And the last one is that a high number of patients will remain on PPIs following RYGB. This probably because many of us bariatric surgeons will continue with PPIs to decrease the risk of a marginal ulcer. So just to conclude, at this moment, we really have limited data. This probably because of the lack of routine endoscopic evaluations in bariatric units. In the recent years have been much more frequently that patients are going routinely into an endoscopic evaluation before the metabolic and bariatric surgery. But the truth is that this can increase costs and many patients won't pay for it. This creates some concern because it will be difficult to have real data regarding the prevalence before surgery of Barrett esophagus, obviously. Barrett esophagus is maybe much more frequent than we thought in patients undergoing metabolic and bariatric surgery. Probably it is between 4 to 6% rather than the 2% that was previously described. That sleeve gastrectomy tends to be related with an increase of Barrett esophagus. So there are some concerns and some questions that will be created from this moment or from the evidence that we have at this moment. Are we creating a risk, or it is just a bias related to symptoms and the follow-up? Probably that patients that are having GERD, and we have much Barrett esophagus because those patients who have chronic GERD following the sleeve gastrectomy will have or will go easily to endoscopic evaluation rather than those patients who don't have any symptoms. Or the risk of Barrett esophagus after sleeve gastrectomy should be discussed with the patient or no. We don't know that, and these questions will be in the air. So the current that, again, I think it's limited evidence suggests that Barrett esophagus may show regression following RYGB. But the truth is, it is impossible and unethical to create proper studies, randomized controlled studies that include high-risk populations of patients with Barrett esophagus, and we can assign them to a sleeve gastrectomy or to another procedure or to RYGB when we have the current evidence that RYGB seems to be superior. I want to invite you to Mazatlan in Mexico in the coming July 2024 to assist to the national meeting of metabolic and bariatric surgery. Again, I really want to thank Sebastián for this invitation. We have two worldwide experts in the panel, Dr. Palermo and Dr. Poggi. So I think if there is any question, and we can continue with further discussion of the topic. These are my data, and thank you very much.
Thank you, Guillermo, for a great session, a great presentation. It was really great. Congratulations on your effort to gather all this data, gather all this information. So, first of all, I like to invite all the audience to put some questions in the Q&A window. You can write your questions, and we will read them to Guillermo and the rest of the panel. So to begin with this discussion, I would like to invite, first of all, Dr. Luis Poggi to make a comment for Guillermo's presentation, and then we can continue with Luciano and Mariano also. Dr. Luis?
Thank you, Sebastián, for the opportunity to talk about this really great talk that we have already listened with Guillermo. Really, it's a very real analysis of the situation of the Barrett's esophagus in the publication, but it's very important to put clear that the progression of the Barrett's esophagus after sleeve gastrectomy is important, and there are some of regression after Roux-en-Y gastric bypass. So it is really, everybody know that, but the analysis and the meta-analysis that we are already seen in this topic in the talk of Guillermo was really clarifying the situation. It is for me very important. In our statistics, the presence of Barrett's esophagus in our casuistic is 6.8% after 2 years of follow-up. So that means a very important numbers of Barrett's esophagus in sleeve gastrectomy. But and we have a coincidence in the results of after Roux-en-Y gastric bypass, because we have a very important follow-up of this group, and the regression is it really exactly that already shown Guillermo in our results in gastric bypass. But in the results of 6.8 in sleeve gastrectomy is a reality. But I think that we need to know which is the patient that who are going to operate, and talk with him about the risk in one or two most important technique, that means sleeve gastrectomy or Roux-en-Y gastric bypass. The patient needs to know everything, and all the information consent needs to be signed with knowledge about the future of his situation. So that is my most important comment. In the other hand, we need to have a very good preparation of the patient, and I think that we need to know which is the results of all the workout that we can do in all the patients. That means make not only endoscopy, perform fluoroscopy, perform manometry, pH, and impedance, because the results are really different. If you have all this information, you are going to arrive at more important numbers. And with only clinically symptoms or only endoscopy, it's really something not too complete information about that. So, but I know that it is very expensive to perform every study in all the patients, and we need to select, and we need to survive all the surveillance of all these patients need to be close. And in obesity surgery, we all of us know that it is not exactly easy. So we need to increase the follow-up. So with this comment, I would like to listen all the panelists to know to do and to say and express all the information that they have. Thank you, Sebastián, for the opportunity.
Luciano?
Thank you again for the invitation, and this was a great review of Dr. Ponce. I think I have several comments regarding, what are we doing and what are we, discussing nowadays? Because probably like 15 years ago, when I was just like leaving med school, we were talking about more like marginal ulcers, gastrogastric fistulas, and nowadays it seems like the most common complication is weight regain and of course reflux and Barrett esophagus. So again, I think we need to remember the key points. GERD is a prevalent disease in obese patients. Barrett esophagus is way more prevalent in our patients. Sleeve gastrectomy, no doubt today that can cause GERD. We have no clue what patients can have GERD improve with a sleeve gastrectomy. I still don't believe that that could happen. There are several other risk factors on top of obesity. So that again needs to keep in mind whenever we choose a patient. The literature is not the best, but it's the best we can probably get. And probably one of the last conclusions of Ipsos statement that is unethical pretty much to do a study comparing sleeve versus bypass in terms of which surgery is better for Barrett's esophagus, I think tells a lot or says a lot. So again, literature shows that progression can happen with the sleeve. And if regression can happen, we'll have with Roux-en-Y gastric bypass. Medications seems in some cases, especially not in the bariatric surgeries, but in fund applications, could be compared when there is actually no dysplasia in terms of therapy. But one very important problem that we really don't talk a lot is that sleeve gastrectomy doesn't have necessarily acid reflux, might have bile reflux. And that's a point that really is very difficult to understand and explain because we don't do pH studies, we don't do impedance studies. And at least in our series, we've seen that there's a lot of patients that will not have acid reflux where PPI will do absolutely nothing. So these patients will have alkaline or neutral reflux and can have this esophagitis progress. So at the end, it's for me amazing that we've been battling to do pre-op endoscopy, and we still keep talking about doing a sleeve gastrectomy on patients with reflux. And I think the reason to do endoscopy before a sleeve gastrectomy is not really finding, or bariatric surgery is not finding tumors or unexpected findings. It's pretty much really assessing our hiatus and really the chances of having reflux of if the patient already has esophageal disease such as Barrett esophagus. So at the end, it seems to me like the holy grail remains patient selection and patient discussion. Patients need to understand the sleeve gastrectomy is a great surgery, but can cause reflux, and especially if the patient has Barrett esophagus, at least in our hospital, if the patient has any burden of disease, not even Barrett esophagus, just a mild esophagitis, that patient will be consulted to get a gastric bypass. And I think that's our way to battle this problem. So my question will be for everybody, how are you dealing this problem? Because we need to think about what can we cause with a sleeve gastrectomy in the long term, especially that's another really important factor. So esophagitis or Barrett esophagus will progress with time. And I think probably it's going to be terrible if in 10 years from now, we'll really have a huge, huge burden of esophageal disease that will require other type of therapies. Thank you.
Thank you, Luciano. Mariano, your opinion?
Thanks a lot, Sebastián, for the invitation. And first of all, I would like to congratulate Guillermo because your talk was great, very complete. And to start, I can say that I agree with Luciano about the evidence. I think the evidence is not the best evidence we can have, but it's the evidence we have. But then I have a question for Sebastián, Guillermo, and Luciano, and which is the real incidence of Barrett esophagus in your practice? Because we see that the literature, we have a lot of Barrett esophagus, but then when we go to the field, I think it's my feeling, it's not so high. Another important thing, I strongly believe that all our patients that we are gonna perform a gastric bypass or a sleeve gastrectomy, we have to do an endoscopy. When we were in Montpellier in the sleeve gastrectomy consensus in 2019, I realized that a lot of surgeons don't perform in the US, don't perform endoscopy routinely in all the patients that are gonna underwent a bariatric surgery. And I strongly believe that at least a pre-op endoscopy has to be performed. Selection of patients is very, very important. As Luciano said, if we have patients with reflux, with GERD, we are not going to offer those patients a sleeve gastrectomy. We're going to perform a gastric bypass. And of course, if we detect Barrett esophagus in the pre-op, we are not going to do a sleeve gastrectomy. Another important thing to finish is that we have to advise the patients about GERD after sleeve gastrectomy. And a question for Lucho, for Luis, what do you do in your office if you have a patient with reflux and the patient don't want to do a gastric bypass? The patient said, I just wanna sleep with GERD. You try to convince the patient because you are the doctor and you know more than the patient. And I also asked this question for Guillermo. What do you do in these cases? Because we haven't said, I just want to sleep, no gastric bypass. What can we do in those cases?
Dr. Luis, one first. You answer. You're on mute.
Okay, thank you. I think that it is a very complicated question because I have many things to convince the patient. If you try to convince the patient only with endoscopy, it's very difficult to arrive to have a very good success. And if you have endoscopy, manometry, impedance, pH, and fluoroscopy, and you show to the patient the risks, mostly I arrive to convince to go to gastric bypass. That is why I have changed my numbers from 70% of sleeve to only 2% of sleeve in my practice. So the most of them goes to the gastric bypass because it is not only to find the results of Barrett's esophagus or esophagitis, reflux esophagitis. The problem not only is that, for me, the problem is that you can arrive in the time to have esophagitis and Barrett's esophagus, not progression or regression. It is things we need to know that we can produce esophagitis, reflux esophagitis, and produce Barrett's esophagus. In the literature, Antonio Gianelli has 18.8% and Alfredo Gemco 17% of Barrett's esophagus in his gastritis after 5 years. So it is not something to forget. We need to have the clear of these topics and all these results to try to convince. It is impossible in 1 or 2 patients to arrive to change the operation, but mostly I arrive to change the operation from sleeve gastrectomy to gastric bypass.
Guillermo.
What I do is, well, first, I really want to thank you, all of the panelists, for the comments. But what I do is, I don't do routine endoscopy for all my patients. I do it selectively. And for those patients who have GERD or some kind of esophagitis or Barrett esophagus, I always propose RYGB. However, many of them will reject it. I try to convince them, and mostly all of them, once I tell them that near to 30% of the patient will get worse regarding the GERD and the risks, they change their mind. But a very few patients, they try to convince me that they only want a sleeve gastrectomy. What I do is giving them a specific informed consent that the risk is this, that can work worse, that even they can change and present esophagitis. I have done it in the recent years, and at least I have 6 patients that I give this specific informed consent. And something really important that I found with this revision is that near to 40% of the patients who develop Barrett esophagus did not have symptoms of GERD. So this is something that we need to take on account. Probably patients had some symptoms of GERD before the sleeve gastrectomy occasionally, but once we made a sleeve gastrectomy, even if the patients do not have symptoms, can have some esophagitis or Barrett esophagus. I think this is really important.
Thank you, Guillermo. Answering Mariano's question about our numbers on Barrett esophagus. We do mostly gastric bypass 65 to 70%. And our main issue to answer this question is we had low numbers, lower than the papers, but our main issue, as many of us, is follow-up. I cannot change our patient to the clinic. I cannot follow the patient. Even we are trying our best to follow our patients, our number are 30% after 2 years. It's pretty low. So that's difficult to answer because our main concern is our follow-up. And talking about this dilemma of trying to convince our patients who really want to sleep, and you try to convince them otherwise that you need a room white. I have pretty much a little of success doing that. I try to explain a lot that almost 20% of our patients with sleep will develop some degree of reflux, and we'll try to explain that room white is not as ugly as it seems. I try to explain to the patient that if you want to do this procedure, you need to take into account that this is not plastic surgery, it's not something to lose weight, it's something to try to learn to accomplish better lifestyle, and the need of a follow-up and supplements and all these things that related to the multidisciplinary approach. And I have more or less a good results trying to convince them otherwise. So Luciano, your numbers or your incidence of Barrett.
As already mentioned previously, at our hospital, I can go from 3 to probably 6% post-op, and the pre-op is probably lower than that. So again, the concern is really post-operative incidence in what to do. So, and I think we really, it's interesting how we make recommendations, for example, like this IPSO recommendations, making a difference between short Barretts and long Barretts. I mean, that's a difference between having less than 3 centimeters or more than 3 centimeters, and those are endoscopic findings and can have, of course, some bias. So it's really interesting how can we make a recommendation. It's all the same disease. It's all the same. So why are we making that difference in terms of making recommendations? Well, that's at least what literatures and experts support, but still not the best quality. I think, again, in order, this is the same disease, we should probably make better decisions. It's a conundrum.
Yeah, indeed. Oh, very well. Thank you all for the audience. We have lots of questions. We will try in the next 10 to 15 minutes, try to answer them all. There are some questions already answered by the panel, but I think is the most common question in our audience, and it's needed to be done. What's your opinion about crural or hiatal hernia repair, and if this will benefit or not our patients to do not have reflux?
Very important, Sebastián. Very important to do a cruroplasty. Of course, if we search in the literature is not very, very strong, but we have, if we have the evidence of hiatal hernia, we have to close the defect if we are gonna do a bypass and if you are gonna do a sleeve gastrectomy. Totally agree with that.
But can we rely on the repair to achieve a really strong improvement in our risk for reflux after the repair?
We will have less reflux. We will have less Barrett esophagus.
Great, thank you, Mariano. One question for Dr. Jacques Himpens. Thank you, Dr. Himpens, to make us this question. It seems that the conclusion is that the sleeve gastrectomy needs to change in the way of practicing it to prevent GERD. So what's the opinion of the panel about NOCA's procedure, that the Nissen sleeve procedure?
I would like to quote Dr. Michel Gagné, because he's, of course, the father of the sleeve gastrectomy, and he has these really wise words. I mean, what are we doing to stop GERD after sleeve? And I think we discussed this about with Mariano. So I think the end sleeve is an option. We still don't have really great data, and still the concern of not being the best anti-reflux surgery and not the best weight loss surgery, but it's still under, I mean, study in some numbers might have really probably, I know, good results, but I'm not doing it as a routine, but probably if I encounter a patient with a really, really severe reflux that doesn't want to have a bypass, we'd probably consider that option. We in fact have done this twice, but no more than that. And it's not a surgery that I practice. But again, I think it's what we need to recognize. It's an effort to deal with this problem that we are discussing today, and that has a lot of value.
For me, Seba, the Nissen sleeve gastrectomy is a very good procedure. We have it in our techniques that we perform. We don't perform it routinely. For patients that have a reflux, our first option is still gastric bypass, but in patients that we can perform a gastric bypass, we perform Nissen sleeve gastrectomy.
Dr. Luis?
In my concern, I think that the Nissen sleeve is a very good theoretical procedure to resolve the reflux. We perform door sleeves in all the patients who had a very big superior portion of the fundus redundance. And with this, we clinically arrived to resolve the reflux problem, but the results in the studies are not the same. I talked with Dr. Nock about the technique, and I think that the modification of the technique can arrive to have a very important results of control of the reflux. But we need to put in the table another possibility. I talked that with David about the tupé sleeve, because it's not too has not too tension, and it's very effective in anti-reflux procedure, and it's not so complicated to perform it. So David told me that he's thinking about that, and he has some trial working about the tupé sleeve. Everybody wants to try, and everybody wants to resolve all the things against sleeve, but because it's a good operation. But the problem of reflux is really the big deal in the reflux in the sleeve gastrectomy. So we need to know the results before recommend the end sleeve. But I think that it's very different to see all the designs that everybody can see in the books or in the papers in front of talk with David Noca on look the operation in the hands of David Noca, that we need to have a very good design of the technique to clarify the procedure, and maybe with unification of this technique, we with a trial of investigation can arrive to have good results and good answers of all these kind of questions. Thank you, Sebastián.
Thank you, Dr. Poggi. Trying to summarize and trying to reach at the end of our webinar. One last question. All of us are experienced surgeons. All of us have at least 10 years doing this. And all of us are very active in the academy. So all of us have this combination between experience and evidence. So for the last part of a webinar, your opinion or your approach to try to lower the risk of GERD on your sleeves. In my example, I try to revise the Yarus all the time. I repair the Yarus if I see something weird on the visual image of the Yarus, and if I repair the Yarus, I also fix the sleeve to the omentum. But what's your approach? Beginning with Dr. Luis.
For the sleeve, I think that we need to fix the hiatal hernia always, because if you have a hiatal hernia, the problem of the sleeve and the problem too of the bypass is the sliding through the hiatus go to the mediastino. So we need to try to stop this possibility. The first thing that I always arrive to do is fix the hiatal hernia. Conventional is dissecting all the esophagus, trying the esophagus back to the abdominal cavity, and close the crura. To put or not to put the mesh, we have a portion of people with mesh and without mesh. For us is the same thing, because now with the barm sutures we arrive to go up and down and for me it's similar to a mesh. And after that I always fix the sleeve to the crura always, but it is not completely sure that all of that are going to stop the reflux problems after sleeve and the sliding hernia. You know, with volumetry, 3D volumetry for CT studies, we have arrived around 74% of sliding hernias. That means hernia because we can see the clips upper in the diaphragm, and we arrive to know that it is a slide hernia. It maybe at that time it begins the reflux, and with or without correction of the fixing of the hiatal hernia or putting the heel stitch in the crura with the sleeve. So we do everything, but we arrive to think that everything is fixed, but at the end, the evidence can arrive to show us that there's an important sliding little hernia in a very big numbers in our evaluation with 3D CT volumetry.
Thank you, Dr. Poggi. Mariano?
Yes, I agree with Lucho that we have to check for hiatal hernia at the beginning of the procedure, and then we have to follow all the standards to do a good sleeve. This means start from 2 to 5 centimeters from the pylorus, go forward to the angle of his and go 1.5 centimeters away from the angle. We have to avoid twists. We have to avoid all these small details that during the surgery we have to be very, very focused on that. And after doing a great sleeve gastrectomy, we will still have reflux and we have to have a strong follow-ups in all these patients. We know that most of these patients, the treatment is with PPI, and the response is good. But I strongly believe that the follow-up after a sleeve gastrectomy is the key point, and very, very important to not to prevent, but to diagnose very, very at the beginning, Barrett esophagus or reflux, and to start with the treatment quickly.
Thank you, Mariano. Luciano?
And I have nothing to add. Do pretty much the same as already mentioned.
Thank you. And last but not least, Guillermo.
The only thing different that I do is I always use a GCT of at least 40 French. There are some authors that have the hypothesis that the smaller GCTs can increase the intrathoracic pressure that increase or could increase the risk of GERD. So that's the reason why I always use a 40 French GCT. The only thing that I really want to add.
I forgot, Guillermo, to say that. Totally agree. 36 or more, totally agree.
Great. So I would like to thank all of you for your time, for your presence in here. I think it was a really great webinar. I would like to finish this presentation remembering you a take-to-home message that it came from Mariano in the last thing he said, also with Guillermo. It seems that the sleeve gastrectomy looks like a very easy surgery to do. It's completely the opposite. It has some key points that remember already Mariano and Guillermo said about distances from the pylorus, shape, and revision of pleura, etc. It's very easy to do it wrong procedure. So we need to address always that. There is not an easy sleeve. There is not a sleeve to perform in 15 minutes or in 10 minutes. That we need to address properly. It's a procedure that can change patients' lives. So we need to address it like that. Thank you, all of you, for the time. Remember, this presentation can be also, it was recorded and it will be uploaded to Virtual Academy. And invite you to the next medical congress in Peru, and then also Mexico, Mazatlan in Mexico, and if so, Global at Melbourne. So thank you all of you one more time, and thank you for your time, and have a great day.
Have a great day. Bye, guys.
Ciao.
Thank you, everybody. Great discussion.